We have an excellent length of presentation in Hall C as well. So to keep things in time, we are starting the presentation, and the first presentation is on path-breaking innovation in diabetes therapy, Degludec IdegAsp. For speaking on this wonderful topic, may I request Dr. Gaurav Bhaduri. He is a consultant endocrinologist at Apollo Hospitals, and he stays just beside here only, and he has a great academic career. To chair this session, Dr. Ashok Mukherjee and me myself will be here.
As a financial disclosure, I have been compensated commercially for this talk. And agenda. So today's agenda will be Degludec and IdegAsp and the clinical attributes. So we'll start with a case study. So this is the first one. So in the initial visit, we have a patient named Ajit, which is changed for privacy purpose, aged 50 years, by occupation an engineer, or type 2 diabetes duration of 11 years, HbA1c 8.8%, BMI 27. He has a fasting of 188 and a postprandial of 218. There is no previous history of hypoglycemia. Blood pressure 118/86, total cholesterol 181, and LDL 124. eGFR 55, urine albumin excretion 200 milligrams per 24 hour. There is a positive family history of diabetes. In the personal history, the patient takes alcohol more than 2 drinks per week, and there is no history of smoking. Exercise, the patient is irregular in it. And medical history, known case of hypertension for last 7 years and hyperlipidemia for the last 2 years. So let us have a look at the treatment history. So patient is receiving antihypertensive therapy along with statins, and these were prescribed in combination with the antidiabetic therapy. Now the current antidiabetic therapy the patient is receiving is metformin 1 gram twice a day, empagliflozin 25 milligram once a day, and subcutaneous injection liraglutide 1.8 milligram every day. There are certain primary challenges that has been identified with this particular patient, which is uncontrolled hyperglycemia that we have seen in the fasting PP and HbA1c in the previous slide. The subject also has a hectic work life, as we know with other engineers, and fears insulin initiation will affect work life due to hypoglycemia risk because there is a positive family history. The patient has seen their family members getting initiated with insulin, and there is a risk of hypoglycemia. Travel often and unsure about taking insulin on a fixed time daily, and this is a problem with many of our busy professional patients. So this is something you will come across in your OPD on a daily basis. Now, even before what insulin you would consider in this patient, the first question would probably be whether this patient needs insulin or not. So most of us would agree that the patient is already on full dose metformin, empagliflozin, and also a GLP-1 receptor analog. And probably the next best course of action would be initiating a patient on insulin if the HbA1c is still uncontrolled. Now, if you look at the ADA 2024 guidelines, what we see regarding this is that, first of all, you will have to reinforce the behavioral interventions like the weight management and the physical activity, and provision for the diabetes self-management and education support to meet the individualized treatment goals. Now, if injectable therapy is still needed after doing everything to reduce the HbA1c, the first consideration should be a GLP-1 receptor agonist or a dual GIP and GLP-1 receptor agonist in most individuals prior to the start of insulin. But like in our case, if the patient is already on a GLP-1 receptor agonist or a dual GIP and GLP-1 receptor agonist, or if these are not appropriate, so in certain situations, these agents may not be appropriate in that particular patient. Or if insulin is being preferred by the patient after listening to the pros and cons of both, then you can directly add a basal insulin. Otherwise, if the patient is, you are putting the patient on a GLP-1 receptor agonist, and if the HbA1c is still above target, you go on to add a basal insulin. Now, why basal insulin in this patient? So we have probably answered this because the Western guidelines tell us to initiate a basal insulin. So most of the Western guidelines will focus on initiating a basal insulin. But if you look at the Indian's perspective, so sometimes what we see is a higher postprandial excursion in our Indian patients due to a higher carbohydrate diet. So higher percentage of carbohydrate in our diet. Now, to aid in the insulin decision where to start the patient on a basal insulin or a premix or a co-formulation or a basal bolus or a basal plus therapy to start off with, this paper by Dr. Howrah will help us in deciding this. So what they are saying is if the postprandial glucose excursion, that is the PPBS minus the FBS, if it is less than 40, we can go ahead and choose a basal insulin as the first choice. If it is more than 74, we can use for the postprandial excursion a rapid-acting insulin. Obviously, we'll need a basal insulin for the fasting control. And if it is in between the 40 to 74, we can use a premix insulin or a co-formulation in 30-70 ratio. That should be the choice number 1. Now, from where do we get these numbers? The value 74 is taken by calculating the postprandial excursion for the diagnostic cutoff for diabetes, that is 200 minus 126. And the value 40 is taken by calculating the postprandial excursion for the diagnostic cutoff for pre-diabetic patient, which is 140 for impaired glucose tolerance minus the impaired fasting glucose at 100. Now, which basal insulin? Now, basal insulin also we have different categories of basal insulin, first or second generation basal insulin. Now, there are certain unmet needs with the first generation analogs. Firstly, they are not truly once daily. Sometimes we need to give them twice a day. Higher variability, fixed time dosing is a big time challenge for busy professionals, and not truly peakless, and they have got a higher nocturnal hypoglycemia rates. So these are the issue with the first generation analogs, which the second generation ones try to overcome. Now, if you look at the ultra long acting basal insulin profile, we have two, the Degludec and the Glargine 300. If you look at the onset of action of 0.5 to 1.5 hours for Degludec, which is a little bit shorter than the Glargine 300 at 2 to 6 hours, both of them have minimal peak. The duration of action again with Degludec is much higher, more than 42 hours, whereas for Glargine 300 it is 30 to 36 hours. Coming to flexibility, which actually Degludec beats Glargine 300 hands down, is 8 to 40 hours, whereas for Glargine 300, it is plus minus 3 hours of the usual timing where we give the insulin. Now, Degludec has a faster onset of action, prolonged duration of action, and a very high degree of flexibility as compared to Glargine 300 that we have already seen over there. Now, coming to day-to-day variability of Degludec versus the Glargine 300. So if you look at the variability of Degludec over a 2 years time frame for 24 hours, this blue bar represents Degludec and the gray one here represents Glargine 300. So we see that the variability of day to day is much lower with Degludec compared to Glargine 300. Now, this data is from the confirmed study. This is the real world evidence, not RCT, but what they found over here was the change in the rates of hypoglycemia demonstrated 30% lower rates of hypoglycemia with Degludec versus Glargine 300. And the change in the proportion of patients experiencing more than equal to 1 episode of hypoglycemia was significantly lower with Degludec versus Glargine 300. So these were very important findings from this real world evidence showing that there was a lower risk of hypoglycemia with Degludec compared to Glargine 300. But we should take this data also with a pinch of salt, because if you look at the BRIGHT study, which was a randomized control study comparing Degludec as well as Glargine 300, it found that they were having a similar kind of glycemic benefit as well as similar rates of hypoglycemia. But remember, that is a randomized control trial in a completely different environment, and this is the real world evidence. Now, if we compare another real world evidence regarding these two agents, that is the DELIVER-D plus trial. So over there, what we saw is that, again, very similar benefit in terms of HbA1c reduction, and what we also saw is that very similar rates of hypoglycemia. But there is a little difference because in the confirmed study, the patients were insulin naive. So they were given either insulin naive patients given Degludec or Glargine 300. But in the DELIVER-D, which is again a real world evidence, there the patients were earlier on Glargine 100 or insulin detamir. So from this group of patients, they were shifted or switched to a Degludec or a Glargine 300. But even if you dig deeper into the DELIVER-D plus real world evidence, though it didn't found that there was any lower risk of hypoglycemia with Degludec, there was a reduction of around 20% reduction in the daily dose of insulin with Degludec versus glargine U300. So that was a takeaway from the delivered D+. Now, in conclusion, Degludec fits the bill. So it is a flat, peakless activity profile, minimizing the risk of hypoglycemic events, long duration of action of more than 24 hours, allowing dosing flexibility. This is probably one of the most important reasons why we prefer Degludec over glargine U300 in practical terms. And minimal variability. This is again the graph that I shown you there. There are also CGM studies showing that there is a much lower variability with Degludec versus glargine U300. Now coming to case study 2, this is our next case. A patient named Amit, name changed again because of privacy. Age 53 years, occupation businessman. Type 2 duration here is around 7 years. HbA1c is at 9.2%, BMI 25, fasting 206, PP 276. So you can again, from a previous encounter, now you have learned to calculate the postprandial glucose excursion. So you can see the difference is around 70 over here. So previous history of hypoglycemia, yes, the patient was initially prescribed sulfonylureas during his treatment over the last 7 years, and he experienced hypoglycemia, and then was shifted out of it and were given a oral semaglutide. We'll look at the treatment history later on. And then the blood pressure is 132/86, total cholesterol 194, LDL 138, eGFR at 60, urine albumin excretion again raised at 150 milligram per 24 hours, positive family history of diabetes, no history of alcohol or smoking, exercise again irregular, medical history hypertension for the last 12 years and hyperlipidemia for last 7 years. Now, in the treatment history, antihypertensive therapy and statins were also prescribed in combination with OADs, but in both the cases we saw that at least the statins were inadequately prescribed or the patient were not compliant. You also need to upscale the statin for both the cases. Current antidiabetic therapy, metformin 1 gram twice a day, tablet semaglutide 14 milligram once a day, and dapagliflozin 10 milligram once a day. Now, the challenges that were identified with this patient, he believes taking insulin will be difficult with hectic daily routine, fear of hypoglycemia, uncontrolled because he has already experienced hypoglycemia, the fear might be a little bit more, uncontrolled hyperglycemia that we have already seen in the reports, having an erratic dietary pattern, travels often and unsure about taking insulin on fixed time daily. Now, the question is again whether you would be preferring to use insulin at all in this patient. For most of us, I think you would agree. If you don't, we can debate about that later. So what insulin would you consider in this patient? So coming to again help us in our decision for insulin making, so we can use this Dr. Kalra's chart again. So here the PP excursion, as I told you, is around 70. We calculated it previously. So the choice number 1 becomes a premix insulin or a co-formulation insulin. Now the value 74 is taken, as I already told you, and how the value 40 we have reached. Now these are the attributes of IdegAsp. Any insulin, to be very fair, would always be attributed these 4 characteristics and will be judged based upon this. So first is efficacy, second is safety, third is quality of life, and fourth is flexibility. So coming to efficacy and safety in the next slide. So what we look at over here is insulin IdegAsp versus insulin glargine. Now, here we can see the percentage change in fasting, postprandial, and HbA1c with 3 arms, one representing glargine U100, the second one glargine U300, and then IdegAsp. And what we see over here that with glargine U100 and IdegAsp, the fasting, there is not much difference, but with glargine U300, the fasting control is much better with IdegAsp as compared to glargine U300 in this particular study. And if you look at the PP, here hands down, the IdegAsp beats all of them. And also in HbA1c reduction, there is a statistically significant better result with IdegAsp as compared to U100 as well as U300. However, so we get a very good HbA1c control, better than U100 and 300, along with better PP control with both the agents, and probably a little better fasting control than U300 and not U100, without any statistically significant difference in hypoglycemia. So you have a similar rate of hypoglycemia, but a better HbA1c reduction with IdegAsp. So that is the best of both the worlds you are getting over there. Now, whether IdegAsp, some patients switching from Glargine 100 or 300 to IdegAsp, that improves the quality of life. So we told you that there are 4 attributes: efficacy, safety, quality of life, and flexibility. So quality of life, this is again a Japanese study where they tried to measure the quality of life scoring. So from at baseline, it was 67.3, and at 26 weeks at the end of study, it rose to 70.6. So there is a statistically significant improvement in the quality of life when patients were shifted from Glargine, either U100 or U300 to IdegAsp. Now, if you look a little bit deeper into the study and see, so around 79% of the people with diabetes were willing to continue their treatment with IdegAsp once they were switched, and around 74% people living with diabetes preferred IdegAsp over their previous therapy with Glargine U 100 or 300. So there was overwhelming majority who were supporting the use of the new agent IdegAsp as compared to their previous agent. Now, this is an Indian study by Dr. Koval, where they wanted to understand the patient-reported attitude, practice, satisfaction, and quality of life on IdegAsp. So this is a single-center study with adult type 2 diabetic individuals on IdegAsp, carried out over 3 years almost, and 245 participants' data analyzed. There were 26 questions in the questionnaire, and the number of questions in the questionnaire has been noted in the left, and Likert scale were used. And what they found is that 89.8% reported improved quality of life, and the primary driver of that was a reduced number of pricks. 86.7% found it comfortable to inject the IdegAsp in different social situations, because sometimes you might need to change the timing based on the social situation. So if you're able to have a mealtime insulin which is flexible, you can move it around, then that could be extremely comfortable to many of our patients. Then 94.2% could manage their day-to-day activities better after initiating IdegAsp. And that is again because of the flexibility that it offers. So how and where does this flexibility come into the picture? So insulin Glargine U100 initiate with a 10-unit once daily dosing. So that's the recommendation. So label indication. So any time of the day, but same time every day. So suppose you are initiating at 10 p.m., then you have to initiate it, you have to repeat it every day at 10 p.m. So you have a 15 minutes window. So 9:45 to 10:15. So that is what we instruct our patients. With Glargine U300, you can initiate with a 0.2 unit per kg once daily. And if your time is suppose 8 p.m., you are initiating this. So 3 hours before from 5 and 3 hours after, that is 11 p.m. So you have to give it in between this range. Now, IdegAsp, you have to initiate ideally with a 10 unit once a day. So that's again the label indication. You can administer with any major meals of the day. So usually we say the carbohydrate heaviest meal of the day you can initiate it with. But if there are some constraints, suppose a patient you want to initiate at the carbohydrate heaviest meal of the day, and that is the afternoon lunch for that particular patient. And the patient says that, sir, I can't take it at lunch, because I am at office and I will feel extremely uncomfortable taking it at lunch. So you calculate the next heaviest meal of the day and add it over there, because you need to improve the compliance of the patient when you're initiating insulin. You have to be extremely flexible from your side also. So how to initiate IdegAsp? Administer with the largest meal of the day, that's the dictum, but you can modify based on your clinical practice. Initiate 10 units IdegAsp with the most carbohydrates heavy meal of the day, and then you can intensify it with administering it BID, so twice daily, with 2 most carbohydrate heavy meals of the day. And even if you fail to control the postprandial surge, so suppose you are given it before breakfast and before dinner, and you still see in the SMBG charting that the post-lunch numbers are still high, then you can add a rapid-acting insulin, suppose only Aspart, before lunch to get a control. So this will help you in managing these cases. So meal size and the postprandial glucose response should dictate the ratio of the doses. And it doesn't have to be necessarily a 1:1 split. So you need not split it equally. It should depend upon how much the glycemic excursion is happening post-meal. In certain special situations also, you can use elderly patients, type 2 diabetic patients with both hepatic and renal impairment, type 2 diabetic individuals during religious fast, adults type 1 diabetic individuals also it is label approved, but in type 1 diabetic individuals we always prefer a basal bolus regime, but in certain cases if you want to manage one dose with IdegAsp, suppose before breakfast, and then you add 2 prandial insulin before lunch and before dinner. If you are able to manage the glycemic variability, which is very high in type 1 diabetics, you can approach this. This, I would say, is better in patients with LADA when they're initially losing their control on oral medication. So 5-6 years later, usually our latent autoimmune diabetes of adults, they will lose their control very early on their oral medication. So in these patients, if you use this IdegAsp once daily and then twice daily, these patients will remain in control for a significant number of years, and probably later on you will again need these patients to be transferred to a basal bolus regime. So in summary, Degludec key attributes is it's almost an ideal once daily basal insulin, long duration of action of more than 24 hours, and minimum variability. And it offers a huge flexibility. You can use it at any part of the day. IdegAsp key attributes, efficacy and safety backed by robust evidence. We have shown you the data. Better HbA1c reduction without causing any extra hypoglycemia. Positive impact on the quality of life we have also demonstrated, and there is extreme flexibility in dose and administration, making it more compliant versus a basal plus regime. So I thank you very much for your patient hearing. I'm here if you have any questions for me.
Thank you, Dr. Gaurav, for finishing in time. Anyway, 1 or 2 questions may be allowed maximum from the floor.
Yes, sir.
I would like to know your views once the IdegAsp, the once a weekly insulin, is commercially available and will be in wider use. How do you see the future of Degludec or even maybe IdegAsp?
Yes. So, yes, IdegAsp and as well as Degludec will have a very strong future. There is no denying that, because IdegAsp, you need to be, first of all, initiation with IdegAsp will be a challenge, because you need to know the total daily dose of insulin, because you are giving a 7 days regime. So suppose a patient is receiving 10 units. So 7 days, it's 70 units. And then 50% you have to add for the first week, and then you go back to 70. So such a huge amount of dosing, and then the scale, Devarati will tell us that probably 10 units it's moving per movement, there is a 10 unit shift. So if you want in any of your patients to move by 1 unit, you cannot do that. So suppose a patient is on, a high risk hypoglycemia patient is on 10 units, you want to increase it to 11 units. So that will mean 7 units addition on the weekly scale. So weekly, you will have to move IdegAsp by 10. So extra 3 points weekly will go. First, this is the issue. So patients with high risk of hypoglycemia, very high degree of glycemic variability, you will find it a little bit challenge to initiate with a IdegAsp. So probably these patients will be first on ultra long acting basal insulin, and once you have calculated the stable dose, then you might consider going in for a shift to IdegAsp. And so these agents will be there to stay. Okay, so I don't see that they don't have a future even with a once weekly insulin.
I have a small query. The studies has clearly shown, I mean, there is data that titration phase is very important for any kind of insulin therapy.
Right.
And if you think of the second gen, ultra long acting basal insulins, there is some benefit conferred by U300 glargine in the data. Now, how do you look at it? I mean, do you think that's a huge point in favor of U300, or maybe Degludec is overall scoring better than U300?
Yes, so U300 is also not a very bad option. So because I'm talking about Degludec, we shouldn't be demonizing a U300. It's a decent option. But if we really look into the flexibility issue, so that is, I think, is a primary driver why we prescribe this Degludec. Because suppose you have given a patient a Degludec in the evening time or maybe night time, which is usually what we do, and that is what the ADA also recommends, except in the elderly population where they say that you shift it in the morning. Now, suppose you are giving this agent to somebody at about 9 p.m. and then you have a 3-year window, 6 to 12 at night. Now, if the patient is supposed traveling during that period, then the patient will miss that particular dose on the right time. So with Degludec, what we can do is we tell the patient, okay, no problem, take it in the afternoon, take it in the morning, no problem. Because first 2 to 3 days, 48 to 72 hours, it will achieve the steady state. After that, whatever time you give, the result will be same. So even if the patient has taken the last dose at 9 p.m., you can give the next dose in the morning 9 a.m. or 10 a.m. No problem. It is not going to cause hypoglycemia. So that kind of benefit that Degludec offers is probably, it supersedes the other kind of benefits. Some data has shown U300 benefit and some data have shown Degludec benefit. We already discussed in the confirmed data versus the bright data versus the delivered D plus data. These are the 3 major data we have. So beyond that is the practical applicability of the insulin. So if we can offer this kind of flexibility to our patients, the patients get very motivated to use the insulin, especially while you are starting it. They don't want their life to be constrained with the insulin.
Two questions. In the first 2 cases, why didn't you consider using sulfonylurea, the newer sulfonylurea, the 3rd generation? And second, the studies which you have mentioned, what is the percentage reduction of microvascular complications in any of those studies if you use this injection?
Okay. So obviously these studies on insulin, they didn't look at the microvascular complication because this will be a long drawn study and none of them were. But we know from already from all the data that we have from the UPPDS with VADT Accord, we know that if we reduce the HbA1c, the microvascular benefit is always going to be there. Whether the macrovascular benefit is going to be there or not is a matter of debate. Now, coming to your first question is whether why these patients were not given sulfonylurea. So the patient is first of all, there is a significant duration of diabetes has passed. So sulfonylurea probably works the best when these patients are drug naive or at the initial stages of diabetes. Second is that the titration that you can do, because both the patients were afraid of hypoglycemia. One patient has experienced it and one patient has seen it in the family. Now, with sulfonylurea, with a very high fasting glucose, probably you will achieve some, even if it works, you will achieve maybe a good PP control. But to achieve a fasting control in a patient who has a fasting PP of around 200 or 200 plus is extremely difficult with sulfonylurea. Second is that the risk of hypoglycemia happening with sulfonylureas is much higher compared to a titrated, slowly initiated dose of basal insulin in the first patient. Next patient in the IdegAsp, you might argue that there is a higher risk of hypoglycemia because there is a prandial component there also. But that patient has already experienced hypoglycemia with sulfonylurea. And we have shown you the data that the rate of hypoglycemia was similar with U100 and U300, which are only basal insulin, compared with IdegAsp. So you get a better HbA1c reduction and almost similar risk of hypoglycemia. So keeping this in mind, this patient was not initiated on sulfonylurea. But yes, this is something that probably every one of us will not agree. Some people will just refuse insulin, and then the doctor will be left with no choice but to try sulfonylurea. It may work in some selected cases, but probably won't work in the majority of the cases.
Because we have the experience of maximum with sulfonylurea and it has a major market share. So if you see the experience, we are more experienced with sulfonylurea than I did.
Yes, absolutely. I agree. But you being experienced about a particular drug doesn't mean that the drug will be able to bring down the HbA1c to the target level. So if we want, because see, the first patient had a HbA1c of 8.8. Even to bring it below 7, that is 6.9, there is a 1.9 HbA1c reduction that is needed. A patient who is receiving metformin full dose, empagliflozin full dose, and injection liraglutide 1.8, very unlikely that after 11 years of diabetes that sulfonylurea addition will be able to bring down the HbA1c to the target without causing the patient a higher risk of hypoglycemia.
Anyway, every good thing should come to an end, and we don't want to experience hypoglycemia.
Right.
So let's stop here, and thanks a lot for your excellent deliberation.
Thank you, sir. Thank you, sir.